This is a very special day, and I'm really excited to have a very honored guest here today with us. Dr. Douglas Bettcher is the former director of the Department for Prevention of Non-Communicable Diseases at the World Health Organization. And he was previously director of the World Health Organization's Tobacco-Free Initiative Department, which then became a key part of the NCD department. So he is Steve, I need you to sit down. Thank you. So Dr. Bettcher is a true Renaissance man. He did his medical degree at the University of Alberta in Canada. He did a Master's of Public Health at the London School of Hygiene and Tropical Medicine, and he did a PhD in International Relations and a graduate diploma in World Politics from the London School of Economics and Political Science. Recently, in the past few years, he has provided the global leadership for the implementation of the prevention component of the political declaration of the high-level meeting of the General Assembly, UN General Assembly, on the prevention and control of non-communicable diseases, and for the World Health Organization's implementation of the non-communicable disease prevention component of the Sustainable Development Goals. So in tobacco control, because I'm welcoming you to the Innovations in Tobacco Control seminar series, Dr. Bettcher was the principal focal point for the World Health Organization in providing this Convention Secretariat support for negotiation of the World Health Organization's first global treaty, the Framework Convention on Tobacco Control. So he was there from the beginning. And then once it was negotiated, he coordinated the World Health Organization's work with the Convention Secretariat to support the comprehensive implementation of the World Health Organization's Framework Convention on Tobacco Control. He was also responsible for scaling up the World Health Organization's country-level tobacco control work as one of the partners of the Bloomberg Initiative to reduce tobacco use. And so I can personally relate to that. A lot of important work, but scaling up in the right way and being effective and making valuable contributions is key. So, Dr. Bettcher was honored with one of our field's highest awards, the Luther Terry Award for Distinguished Career in Tobacco Control and his lifetime contributions. He was awarded that at last year's World Conference on Tobacco or Health that was held in Cape Town, and it was extremely well-deserved for this huge role that he's played and impact he has had sitting at the World Health Organization and helping to move forward the Framework Convention on Tobacco Control and all the other tobacco control work that's been done at the World Health Organization. So I'm going to leave it there so we can hear from the man himself about public health history in the making and hearing his insights from those contributions. So thank you, Doug.
Right. Thank you very much, Joanna. We started, I think, Joanna, about 4 or 5 months ago trying to coordinate our calendars and find out when this might work. I've been many times to Johns Hopkins. We used to come every summer for the summer course, which was very popular. And then probably now 3 or 4 years since I've been back. So it feels like coming home. And we finally were able to locate a time when Joanna and I would be going to a same meeting in New York tomorrow as well too, so that I could pop down and be with you. So thanks a lot. I'm really glad to be back here. Joanna's already popped through what's very complicated CV. But when I was doing the genealogy of the Framework Convention, then I also started looking kind of like a mini psychoanalysis as well too of how I got involved in tobacco control. And I thought I'd run through my journey in my own career as well too, because it certainly wasn't linear. I wouldn't say that I'm an accidental tobacco control expert, but it wasn't evident to me. And so I started to, in preparing the presentation as well, to look at, how are you? Looking at how certain key points along the route that might have provided certain competencies or interests that might have inspired me eventually to get into tobacco control. As I said, my journey into public health and tobacco control didn't follow a linear path at all, actually. I'm certainly glad that it eventually led me to where I ended up in WHO and working with different partners. But certainly as well, it emphasizes as well too that we could, I think, try, but probably my experience is that you can't plan your career by every nanosecond over several decades, actually, that just probably doesn't work, actually. Leave yourself open, be a bit courageous, be a bit of a Jean-Paul Sartre existentialist. So starting here at University of Alberta, great medical school out in the west, very cold, but really conservative. I mean, 4 years of medical school there, I think by the time I finished medical school, I couldn't have defined public health or what a public health career would have looked like, actually, because it certainly was not at all a priority for the medical faculty. And in fact, I became somewhat an obsessionist about becoming a brain surgeon. Spoke morning, noon, and night, and did all my electives in neurosurgery until it's a good thing that a good friend decided that we should probably do an elective away from North America, and I ended up, and that's a blast from the past, actually. So the late 1970s, my last few months in medical school, ended up in a small country hospital in Port Antonio, Jamaica. Well, that couldn't necessarily inspire me to think that I was going to do global public health for the rest of my life. But it certainly, and I think that's important in our careers, it opened my eyes, made me think that I should be a bit more broad-minded about different possibilities in my career. So rather than jumping, and this is Miss Martha, who ended up to be one of my favorite patients, actually. She was a very powerful person in Port Antonio, Jamaica. She was the head of the vegetable market, actually. So healthy foods for a rural town in Port Antonio, Jamaica. Did a traditional sort of credentialing myself at Mount Sinai Hospital in Toronto, did a bit of intensive care. And then by a coincidence, actually, I was really attracted to that experience in Jamaica. My two colleagues from India, two specialists, went back to their family practice in India. And so I took over their clinical practice and working in a small country hospital in Port Antonio. So still very much clinical medicine, a little touch of public health, but I still had not jumped into public health in any meaningful way. Went back to Canada for a short time. I had still an itch for global public health. I ended up in late 1984 being recruited by an NGO that was supported by our Prime Minister of Canada. And there I am, actually, in the back, wrong way around, in the back of this picture. Actually, it's a Maclean's magazine working in one of the famine camps in Ethiopia during a big famine. 1 million people died in 84, 85. There was the Live Aid concert. Many of you are too young to remember that, so you might want to reflect on the last few clips in the movie Bohemian Rhapsody as well too. That could probably provide some sort of context to the era. So, and I think this really jolted my moral compass as well. A middle-class kid coming from a family in Western Canada, comfy home as well too. Being put in an emergency situation like that, it changed my moral compass and changed to a certain degree, I think, my direction of work to the extent that I stayed in Ethiopia for 3 years, and that's where I was introduced first to public health. Working with UNHCR through a Canadian NGO, but we had the mandate from to repatriate 500,000 people, 500,000, let's go back, 500,000 refugees living in the Somalian border camps. This had been one of the least developed areas of the world, and there was a war there in the early 1980s, and about 500,000 people were living in border camps here in Somalia. It was to repatriate, and my job was to set up a expanded program of immunization in an area where the average daily temperature was about 110 degrees. Maternal child health, rebuild war-torn hospitals, etc. So this was my first sort of foray in public health, and I decided that I was starting to move in that direction, that I would go to global public health. Well, we did a space travel back to close to Toronto at Hamilton General Hospital, and worked for 3 years into one of the biggest intensive care units as a critical care physician, brain surgery, cardiovascular, med-surgical intensive care, burn trauma. Saved a lot of money so I could go back to school. But I think this is where the first inklings that I had to do, that prevention and public health was certainly very important. Living in one of these domes of high tech, everyone is on life support. All the major NCD risk factors were represented. Almost all of the coronary bypass patients, maybe half of them were smokers, overweight, harmful use of alcohol, you name it. So that, as Joanna said, I went through what some of my colleagues in clinical medicine in Canada thought was pretty manic, actually, going back to the UK and doing something completely unorthodox, getting my Master's of Public Health at the London School of Hygiene and Tropical Medicine, but going on and doing a PhD in international relations, including international law, which turned out to be, it was one of my interests, and it was just, something that I felt was very intellectually stimulating when I got in the track in LSE. And it turned out to be something quite useful because it related to being the coordinator for the negotiation of WHO's first treaty. So bringing together diplomacy, international relations, medicine, public health. So I think those of us that are developing careers in public health, in particular in tobacco control, this multidisciplinary inquiry and curious mind, I think, really is an important, some courage, and can really help us along in our career. And so it was a busy 20 years in WHO before I retired last summer as the director of the Prevention of Non-Communicable Disease Department. I'm doing some consulting and advising on tobacco control, prevention of NCDs in the Director General's office now, who happens to be the former, it's interesting, the loops in life actually, that Dr. Tedros was in the country at the time when I was practicing there, when I was working there. He is the Minister of Health later in his career, Minister of Foreign Affairs actually. So we compare stories by time, and of course his native country. And this was a crowning moment, and I think that it's all about teamwork, whether it was in the intensive care, whether it was in the famine camp in Ethiopia, whether it was helping to build the WHO's first treaty. Some people claim that they're the architect of the Framework Convention. I would never say that. I was one of the cogs in the wheel, actually, and was honored to play the role I did, but receiving the Luther Terry Award, he was the Surgeon General for John F. Kennedy in this country and released the first tobacco report in 1964. And I was completely amazed to receive this, and all I could, my quote there was that it's such a privilege, but really it's an award for our team, actually. And that even includes our Johns Hopkins team and the whole team of Bloomberg and the groups I've worked with and around the world. I couldn't have done this myself. So WHO, just very quickly, specialized agency in the UN system. We have our own governing body. Our constitution, attainment by people at the highest of the highest possible level of health, and certainly the Framework Convention on Tobacco Control is an instrument that really has proven itself to be a method to deliver that highest level of health, and I'll walk through that. Although we have 150 offices, Steve Tamplin worked with me during the negotiations. He was in our Manila office, so we have 6 regional offices, 150 country offices, the headquarters office. But as I say here, it looks a bit small when you think of all the stuff that's crammed in there, actually, compared to the huge medical centers and budgets you have at universities like this. But it works, and I've been very lucky to have an interesting career there. Dr. Tedros, the new Director General, is putting a lot of emphasis in his roadmap, what's bureaucratically called the General Program of Work, as a roadmap for the next 5 years. And he focuses on the triple billion, so impact at country level, so 1 billion more people benefiting from universal health coverage, which is obviously a very important topic in your discussions in this country, ongoing discussion, I think. 1 billion more people enjoying health and well-being, 1 billion more people protected from health emergencies, and the Framework Convention Tobacco Control really weaves through and will help to attain many of the goals through these targets. So let's get to the topic at hand. So I jumped on board in the late 1990s in tobacco control after that very circuitous travel that I described. The background of tobacco control that I inherited was from the 50s to the 70s. Of course, we had the Bradford Hill Dole study in the 1950s that showed the unequivocal link between lung cancer and smoking, the 1964 Surgeon General's report. But between 50 and 70, there were ideas of regulation and controlling tobacco use through regulatory means, but not much happened. The tobacco industry was pretty well unopposed. Looking in the rearview mirror, then the 1970s and the mid-90s, we see pioneers like California in this country, Singapore, Brazil, other countries, Norway, and then the negotiation of the Framework Convention, WHO, ramping up global leadership to make sure that tobacco control would be a permanent priority on the global public health stage. And with the entry into force of the Framework Convention, I would say that we have entered into a new era, an unstoppable era in tobacco control. And the history of public health in tobacco control, at least, will never be the same. So there were I think that all the stars were aligned, so to speak, in the late 1990s to make this happen, because it's no small issue to get all 192 countries of WHO at that time in late 1990s to say that they would like to negotiate a binding international law. I think those who are Americans in the audience probably know that it's quite difficult to talk to your Senates and Congress about international treaties, and you got to get all countries saying that this is a good thing to do. Well, the overwhelming evidence was there. We also had the strengthening economic evidence of the very negative effects of tobacco use, strengthening evidence on the cost-effective measures to reduce tobacco use. The landmark case, the Minnesota Blue Cross Blue Shield case in this country that released 35 million pages of documents showing the criminal activities of the tobacco industry across the world, how they've been targeting developing countries, et cetera, et cetera. Many of you know the story. Then having the leadership at WHO, having a Director General, Dr. Brundtland, who had the courage to jump into a very politically sensitive domain like this, having herself been Prime Minister, having been the head of the Commission on Sustainable Development that led the negotiation of some of the big environmental treaties in the late 1980s, 1990s, a visionary and a very courageous person. Civil society pushing governments, but also compared to 20 years, and I hope we get back to that, I was comparing the attitude towards multilateralism in the 1990s. And I think we had a window, certainly in this country and globally, where all countries still could see the benefits of regulating certain negative sides of globalization through international cooperation and binding treaties. Right now, we're going through a different phase where countries are looking for their own benefits, wanting to make their countries great again, pessimism about multilateralism as well too. But it's quite clear at the same time that the lesson learned of the Framework Convention, we have major public health challenges, whether it be air pollution, antimicrobial resistance, obesity, etc., that have some of the telltale transnational features that probably, likely, definitely need international cooperation. And so where we were before the negotiation of the Framework Convention, we knew that tobacco obviously was a killer product. We needed a global response, and we knew that the tobacco industry was ruthless and after us. The World Bank really helped to push forward the economic evidence with the Curbing the Epidemic report that also showed the economic benefits and health benefits of implementing core demand reduction measures. Actually, what is it? The measures and the analysis here were instrumental in defining the core of the Framework Convention and also eventually Empower. We were at a loss actually for really knowing the situation in the tobacco epidemic. We had very patchy prevalence data from developing countries, especially. No trend analysis. We had not much idea about what particular policies were in place, especially in developing countries. I used to get questions during the negotiation, which countries in Africa have full bans on advertising. I couldn't really answer the question very precisely. And it was thanks to some very brave leaders. One of them is Ruth Romer from UCLA, who started writing along with an American international lawyer, Alan Taylor, started writing about the needs for a global legislative action against the tobacco epidemic. Also, Judith Mackay, who is one of my mentors, she was the reason that Dr. Brundtland actually created the Tobacco Free Initiative and decided that when she was elected DG, that one of her top priorities would be tobacco control. Judith Mackay really, for 40 years, has been a huge leader in tobacco control, despite repeated attacks on her. This is a quote from a U.S. smokers' rights group, nothing more needs to be said. And at the same time, when we started the Bloomberg Initiative, she was nominated as one of the 100 most influential people in the world, and certainly has been, for me, one of my major mentors. So as we started the Framework Convention, WHO realized that we really would have to go did someone, the mouse, okay, that we would really have to take on the tobacco industry in a big way, that the industry was already trying to stop the negotiation of the treaty. And this was one of our World No Tobacco Day videos describing this challenge. So WHO had to become much more in your face and much braver than they had been previously, actually, with our communications, et cetera, since we knew that we were going to be taking on the war with the tobacco industry. So getting into the part when I joined the process, both Joanna, being a Canadian myself, are very proud that this was actually Canada that pushed this forward into what's the World Health Assembly, which is like the global health parliament that meets to every May in Geneva to determine WHO's work plan and our budget, et cetera. So this was a great accomplishment. And then, as I said, the reason it went forward was the courage and stamina of Dr. Brundtland, who immediately, when she was elected, called for the immediate priority for negotiating WHO's first treaty. And this wasn't only tobacco industry and external forces that were against this. It's well written as well, too, that we had our legal office in WHO that was quite conservative, that felt that this would be too much work, too dangerous for the organization, that there might be reputational damage, et cetera, et cetera. It was a heavy lift, actually. Thousands and thousands of hours. Steve was there with us, often in Geneva and out in the field between negotiation sessions. When I hear about the Brexit negotiations and the polarization of views as well, too, it brings me back to the negotiations of our treaty, because in any tough negotiation, you see this vast array of polarizing positions. The industry was fueling as well, too, to try to kill the whole process. But in the end, it was resolved. Hopefully, Brexit will also move the same way towards resolution. And also, at the same time, countries were walking the talk. Canada itself introduced the first pictorial warnings as part of the power of the process during the negotiation. Not soon after the treaty was adopted, then Ireland became the first country to completely ban smoking in all public places and workplaces. Of course, California in the US and also New York City had already done so, but no country had done that. And certainly these were results of what we call the power of the process and the leadership, not only of WHO, but civil society and partners all around the world. And this was the historic moment when this treaty was adopted at the World Health Assembly, never seen before. Some thought that WHO was too conservative and it would never happen. And then for treaties to gain a life, actually, just to have an adoption doesn't give a treaty a life. It's not really alive. For it to be legally binding, there has to be some formula in the treaty which gives it that entry into force, which gives it those teeth to be binding. And that was 40 countries had to ratify it. And this was the record period of time, actually. No other treaty in post-Second World War era modern international treaty law had entered into force so quickly, less than a year and a half. There was a big party. I think I'm down here. I don't see you, Steve. Maybe you were in...
I sent Bill Keane.
Oh, you sent Bill Keane, your colleague Bill Keane, yes. So this was the beginning now of the big challenge to implement this thing. There were huge expectations. Starting from the very beginning, given my background as well too, and understanding both the public health and the international legal sides, since WHO had done nothing in this domain, it was very hard for delegations to understand what we were talking about. I mean, what's the difference between a comprehensive treaty like the Law of the Sea versus a framework convention like the Framework Convention on Climate Change? So right from the very beginning, I said, let's just build a house. We'll express it in a house. So a framework convention is like an unfinished house. You have the foundation of the house, maybe the skeleton, and you continue to build parts of it, actually. Like recently, only 6 months ago, the protocol, which is a separate treaty, protocol to counteract illicit trade, to actually end illicit trade, entered into force. I'll describe that a bit more. And then there are other components that may be added down the line. You create also a governing body, a conference of parties. Unfortunately, the U.S. is not part of that yet, so I think for those of you who are U.S. active citizens, it could be good to keep lobbying to make that happen. And also a dedicated secretariat that is, in this case, embedded in WHO, but separate from WHO. So we work with them together. It was a unique treaty in the sense, because I would classify it as a drug control treaty. Tobacco is a drug. No other drug control treaty had ever included demand reduction measures. They're usually supply measures of illicit trade or licit trade. So this was a very brave way forward to identify price measures, tax and price measures, and then the other empower measures, which I'll describe. And the first 10 years, this was my quote at the 10th anniversary of the Framework Convention of its entry into force. seeing very rapid engagement. Almost all countries in the world. It's now 181 at the 10th anniversary. I think it was 179. Let's leave just a handful of countries. US, Indonesia, Argentina. But there's an analogous one. Argentina as a country, even though it's not a party, has been able to do tremendous work as far as moving forward what's in the treaty without actually ratifying. I wouldn't recommend that, but it is possible. So, to actually make this understandable to the at the 10th anniversary, we celebrated the Framework Convention. But then the question is how to translate to the public so they would understand what a Framework Convention is. A treaty, rather than getting into the technical points, it's a lifesaver. And certainly we know now it is a lifesaver, and I'll tell you how we know that, actually. So the big job of implementing the Framework Convention, WHO's role, obviously, to work with countries, create multi-sectoral coordinating groups, political advocacy, surveillance, etc. Amazingly, after almost 20 years of the negotiation of the Framework Convention, still 19 countries, mainly in low and middle-income countries, don't still have a focal point for tobacco control or for the implementation of the treaty. This was the next major milestone. I think we would have never ever been where we are without the Bloomberg Initiative to reduce tobacco use and partners, including Johns Hopkins. And this was the appreciation of our previous Director General, who helped to launch the WHO's part of the, Dr. Margaret Chan, to launch WHO's part of the Bloomberg Initiative. I think you were at this function in New York, both of you probably. So this was, without Michael Bloomberg, I think there's no way that the implementation of tobacco control measures in the Framework Convention would be where we are today. And I suppose that includes this university as well, too, since he has just donated $1.8 billion to this university, I understand. But for tobacco control, there was great political momentum after the treaty was adopted, but very short of investment to implement it. Great expectations. So having invested $1 billion now over the last decade, and also bringing in Bill Gates as well too, to invest $300 or $400 million into work in Africa, has really changed the whole face of public health and certainly tobacco control forever. And that picture actually was when we first were launching the Empower, the first global tobacco control report, which I'm going to dig into right now, because we felt that you needed to translate the Framework Convention into something that would be practically understandable for countries, where we could have a focus, where we could show a result, where we show an impact. We find ourselves now that we're completely in line with Dr. Tedros's thinking as well, too, the triple billion, that you've got to make a difference at country level, WHO working together with partners, civil society, countries. So we translated the same way that a different concept, but a technical package that some of you may have heard of, the DOTS package for TB prevention and treatment. So we said that for non-communicable diseases, we needed a package. We needed a proven package with hardcore interventions that we could work with partners, scale up, and show the evidence of impact. And amazingly enough, as I said, the Framework Convention was very unique, and it included demand reduction measures. These Empower measures map out to several of the articles of the Framework Convention. So the Power package, certainly banning smoking in all public places and workplaces, essential. The O, which I call the orphan in Empower, because there's so little investment still in developing countries. We're making ground with toll-free quit lines in many developing countries, incorporating brief advice into primary health care facilities. some treatment medicinal support, and also India, for example. We've launched a very successful private-public partnership of using mHealth, mobile health, with another specialized agency of the UN, the International Telecommunications Union. We're in about 14 countries now. India did a spectacular job. They launched the mHealth tobacco cessation, and within 6 months, 2.1 million smokers, tobacco users, including smokeless tobacco, had registered with some very good success rates. The warning about the dangers of tobacco use, so the graphic pictorial warnings, and now the very courageous example of plain packaging, which exists now in over 20 countries. 20 countries are either have plain packaging or on the way. Also, the warning about the dangers of tobacco use through media campaigns. These were almost unheard of before we started the Bloomberg Initiative, but especially Vital Strategies in the Union have worked with countries. Here's an example of what came out in the early stages of the initiative in Turkey.
Çocuklar büyümek ister. Bizi taklit eder, hayatı bizden öğrenirler. Bizi izler, biz olmak isterler. Sağlıklı nesiller için sigaradan vazgeçin.
Unexpected success. They're the first and only country now to have a perfect score on Empower, which I'll describe later. So, of course, then the tobacco advertising promotion sponsorship bans, which I call pushing the mute button in the tobacco industry. This one has been really hard to scale up, and actually low and low middle income countries have been doing better than high income countries in achieving this one. And then the most important, some economists call it a phenomenal Best Buy, increasing tobacco taxes and prices, and how to relate that as well to something that WHO and partners are recommending to countries, that it's really sexy, really a good thing to raise prices, actually. So we actually took that on a couple of years ago for World No Tobacco Day as well, too, which I think this video explains. Oh, no, I'll have to go back to it, and we'll go.
Every 6 seconds, another person dies from tobacco use. And kids my age could get hooked on tobacco before they know it. But there's something we can do about it. As tobacco taxes go up, death and disease go down. Any questions?
This is really in line with Dr. Tedros's view of WHO. He feels that he describes WHO as a bit of a shy organization, that we have great successes, but we're a bit shy to communicate with them. So it's all about, I think those you follow his Twitter page, whatever, follow him in different ways. I mean, he's a real communicator. He wants all staff and to explain in understandable terms what WHO is doing to make an impact in countries. So these types of things resonate very well with him. So the Global Tobacco Control Report has been one of the major foci for the entire Bloomberg Initiative. It would be the most prominent thing that WHO has been doing. We're on our 7th report to be launched this year. It's not just something to put on a bookshelf. It has been the mechanism actually to highlight then the achievement and then also the impact of countries and following in a micro precision both the implementation of these core interventions from the Framework Convention, also moving into compliance, actually. And I'm actually going to be speaking with some of Joanna's colleagues right now, because we're doing an interesting process looking at improving the way that we monitor compliance, for example, smoke-free spaces in developing countries, including crowdsourcing. And one of your teams here has expertise in that area. So the progress has certainly been irrefutable. When we launched with Michael Bloomberg and Margaret Chan in 2007, there were 1.1 billion persons covered in a country one of these Empower measures at the highest level of achievement. So that means 100% bans on smoking in all public places, workplaces, 100% ban on tobacco advertising, promotion, sponsorship, taxes, 75% of retail price or more. And that went up, the last launch that I did with Dr. Tedros and Michael Bloomberg in New York 2 summers ago. There we went from 42 countries to 121 countries with at least one of these Empower measures, the highest level of achievement, and up to almost 5 billion people now covered by one of these measures. And then to look, we're able to actually look at impact. This shows the changes in the 2 years between GTCR 5 and 6. So the blue bar is the increased number, percentage of world population covered. Still not making enough progress here in taxes. That is the critical point, and I think something that probably Joanna and I are going to be speaking with partners next couple of days in New York. But we have seen since 2007 and the implementation of the Framework Convention, steady decrease in tobacco smoking prevalence in the world. Less so in low-income countries. But if we look at targets that have been set by the Sustainable Development Goals and by WHO, the rates of reduction are not enough to reach the target. So progress is being made, but not enough. We can see this was a really interesting study that was published in the Bulletin of the World Health Organization, and just after 3 years of our launch of Empower, taking the 41 countries who had implemented one of the Empower measures at least between 2007 and 2010, and then mapping out how many lives would be saved over the next decades as well too. Of course, the highest impact tobacco taxes, smoke-free places, then pack warnings, and also impact from marketing bans, advertising bans, and cessation support. And then to actually show prevalence reduction. As I said, Turkey as a success story, the only country that has implemented to date all of these Empower measures, the highest level of achievement, was able, coming from quite high prevalence rates, but representing a 13% relative reduction both for female and male smoking rates in a 4-year period. So we're able to show, the first time really in NCD prevention, to actually show those tangible benefits and outcomes at country level, and also then to project the lives saved. This summer, something to look out for, we're going to be launching the Orphan offering help to quit as well too, but of course then giving our updates. I hope we've gained at least another 1 billion people covering at least by one Empower measure this summer when we launch the next theme. So as I said, this house continues to grow actually. This is the whole idea that Framework Convention doesn't include everything, and you can't in any treaty anyway or any law. Over time the situations change. But with 40 parties last September, this new treaty entered into force, so it had been given birth by the Framework Convention. This was the complicated process, which actually even goes earlier than this, actually. 20 years ago, if I put a bet, I'm not a betting man, but if I had to put a bet on which would be the first treaty protocol to be given birth by the Framework Convention, I probably would have said cross-border advertising. This was on the agenda 20 years ago, but I thought it might be too complicated because 97% of its content doesn't involve public health people. It's law enforcement officers, customs officials, attorneys general, et cetera, smuggling people. But then with the rise of the use of laundering of money through terrorism, terrorist networks as well too, even, and other tax concerns after the financial crisis, the leeching off of revenues by smuggled products where no tax was being paid. This one had the political power put behind it by many different sectors of governments to move it forward, actually. It was very complicated to negotiate. I was involved as the head of the interim secretariat in these early days, 2005, 2006, 2007, to give the protocol legs to start negotiation. Then they went for 5 years till 2012 when it was adopted adopted in Seoul at the Conference of Parties, and then it's taken over 6 years actually to get 40 parties. But so this was really historic, very touching as well too, to see in 20 years now. This is the first meeting of parties of this the 40, I think 42 at that point, and already I read yesterday there's 50 parties to the treaty, and focusing on tracking and tracing illicit trade products and to eliminate smuggling. Now, in closing, I thought that it would be good to look if I had a crystal ball in the 1990s, actually, to look at things that have happened and developments, and then we would be the wiser, and then we could have already helped to put in more content actually in the Framework Convention to deal with these issues, but of course that's impossible. We're not all-knowing. So electronic nicotine delivery systems, which in themselves are not tobacco products, but many countries regulate them as tobacco products, some as medicinal products. The first time I ever saw one of these was in Beijing in June of 2005. I'm not sure if you were with us. We were with about 14 ministries in Beijing, high-level officials of the Chinese government to get China to ratify and become a party to the Framework Convention for the first Conference of Parties. And somehow some side event or something, I mean, a marketing representative came up to me with some cartridges of nicotine and a very rudimentary e-cigarette device, actually, which we didn't really comprehend entirely, but in the coming years we understood the implications of this product, which has totally globalized now and has morphed into all types of devices, including Juul, which your FDA in the US has concerns about its rapid expansion, and also whether these are gateway products for smoking. These questions are still open questions. WHO is maintaining an open mind in this area. There's thousands of different flavors that are being plugged into them. And then, if not to make things even more complicated as well too, the heated tobacco products, because the industry is being very surreptitious here. Again, we knew that they were working in the 70s and 80s and 90s on novel products, but when they were launched, they were not very successful. And these products, the industry is trying to morph them together. Heated tobacco products, which are tobacco products, should be regulated as tobacco products. But the Framework Convention, having said that we couldn't foresee everything, we did include Articles 9 and 10 on product regulation, realizing that tobacco products and maybe derivatives that would come in the future were already under-regulated, and there could be some regulatory challenges in the future. So these issues are covered through the Framework Convention and are being tackled head-on. They are regulatory conundra, and we'll have to, I compare certainly the e-cigarette issue to a kind of living natural experiment that we're experiencing. Then, I mean, something that couldn't have been, and this has a certain personal connotation for me as well too, that the tobacco companies would then be launching and providing, like Philip Morris did, $1 billion to launch what they called independent foundation, smoke-free foundation for a smoke-free world. Which WHO sees as absolutely contravening the Framework Convention. The Framework Convention includes an Article 5.3, to ensure that governments do not compromise their laws due to the lobbying and vested interests of the tobacco industry. And WHO has responded to this in a very clear fashion. The WHO will not partner with the foundation and recommends to governments and other foundations, academic institutions, and it's great that Johns Hopkins was quick off the mark to say, no way, we're not collaborating with this organization. So that was certainly a development as well too, in two ways that one could not foresee during the process of negotiation of the Framework Convention. And then some very interesting, we knew that trade issues and investment issues were interesting. They were much discussed but could not be actually incorporated directly into the treaty. But we knew that there would be legal challenges to the Framework Convention. These have been very interesting. when Philip Morris sued Uruguay about 8 years ago using what's called a bilateral investment treaty between Switzerland and Uruguay, having nothing to do with tobacco, by the way. But Philip Morris used this bilateral investment treaty to sue Uruguay over their 80% front and back warnings. It was really a David and Goliath type of success story. WHO, I think the organization, our Director General was extremely brave in this sense that we set history in this area of international law by WHO submitting an amicus brief. That's a fancy legal word for a testimony based on evidence that what Uruguay had done was evidence-based. And also Michael Bloomberg provided, I think, well over $1 million to support the legal costs of Uruguay challenging this behemoth, this huge legal machine of Philip Morris, and they won. And that set us up for the next controversy was 4 countries. It was originally 5, but Ukraine withdrew, challenging Australia on plain packaging in the World Trade Organization, which is also headquartered in Geneva, claiming that the plain packaging is more trade restrictive than necessary. Just last June, they lost the case, those claimants. Australia won. WHO, again, along with the convention secretariat, we submitted an extensive legal brief, again, an amicus brief, which was seen to be very helpful in the case. And also it's interesting that the different claimants from the tobacco industry have failed all of the other litigation cases that they've jumped into as well too. And we've seen now globalization of the worst nightmare of the tobacco industry, because this was something they were already getting very paranoid in the early 1990s. We know from the litigation, the 35 million pages from the Minnesota case, that all the tobacco companies were coming together, a bit like cockroaches as well too. When they're really concerned, they come together. And they wrote a strategy in the early 1990s, before WHO or any country was talking about implementing plain packaging, about how they would undermine any country, kill any country's efforts to implement plain packaging. So that was like 20-some years before Australia did it. So now we can see that this movement and the power of the process instigated by the Framework Convention has been extremely successful, because there's over 20 countries now that have either implemented plain packaging or are on the way, actually. And as a final note, so for me personally as well too, to see after 20 years as well too, that the Framework Convention as well too, in the heads of states that negotiated the development roadmap for the world from 2015 to 2030. I think you know the Sustainable Development Goals, that under the health goal of the Sustainable Development Goals, the strengthening of the implementation of the Framework Convention is included. So that was a really changed the face of public health history. And I would say some have even said that for WHO that this is equivalent or can be compared to the success of smallpox eradication, the success of the negotiation and implementation of the Framework Convention. So that's all from me.
Thank you so much. Hello? Thank you so much for the wonderful presentation. When Foundation for a Smoke-Free World was announced a little over a year ago, there was a lot of concern that they would get a lot more influence in low and middle income countries where they're a little bit more resource starved in these matters. Are you aware of the extent of those efforts in the year since, and if they've been successful in those pursuits at all?
They're not too open, as one would expect with their interventions, but we do know that they are trying to especially intervene in some of the lowest income countries on issues like crop diversification in Malawi. They're trying to infiltrate India, and are trying to also provide political pressure in countries or subnational authorities like Hong Kong. I know that the president was in Hong Kong some months ago as well too, and members of the foundation entering China as well too, to encourage the legalization of not only e-cigarettes, but what the ultimate aim for Philip Morris is to push these heated tobacco products as well too. They say they're completely independent. They claimed when they launched it, they were quoting, maybe Joanna has something to say about that, but certainly they were quoting a paper by Joanna and Mitch Zeller that they had used 8 points that were laid out in a paper of what an independent entity could look like that still, I think, could accept tobacco industry money. They claimed when they launched this thing, and this was claimed falsely, that they had used these 8 characteristics or to structure this foundation. There's no evidence from our side, from the public health side, that the approach that has been taken actually is doing anything more than just muddying the waters actually and creating confusion. It was interesting recently that the president of the foundation issued a letter to the countries of our executive board, our governing body, 1 month ago in Geneva. And at the same time, the CEO of Philip Morris as well too, even though they claim to be separate, launched also an open letter criticizing, castigating WHO's for its lack of interest in harm reduction for tobacco. But harm reduction on tobacco according to their rules, actually. It's a paradigm that they are pushing, which is not open for debate.
So the global tobacco movement has been really, really successful. And I know from speaking with colleagues working in other public health areas that they too are aspiring for a framework convention.
Mm-hmm.
So, for example, alcohol, road safety. And so I'm wondering, based on your experience, what recommendation would you give these other public health advocates working on other issues who want to, have a convention, a framework convention?
Okay. Do we want to take this other question at the same time, or no?
Sure.
We can fold them together, actually.
Thank you. Actually, I was building a little bit on Connor's question. So the way you presented it.
So Sarah, who was my professor actually some years ago.
Well,
yes.
that was a very long time ago.
Well, I don't know, that's early 90s actually. When,
Yeah.
Yes. So,
So the question
Great.
was really about the role of international treaties.
Yes.
And you sort of suggested that they was quite central to what has been achieved in terms of tobacco control, but they're so time-consuming and so difficult to put together.
Right.
Do you have recommendations maybe for these other industries and sectors about how to proceed and whether an international treaty is critical or whether there may be shortcuts?
Yeah, I was moderating a plenary at the Prince Mahadal conference in Thailand just recently, where we were talking about governance issues and industry interference as well too, and regulatory approaches like treaties as well too. And at the same time, I said that I think we can't take a cut and paste version to solve other issues. Certainly, there's many candidates areas where there's interest in potentially a binding treaty approach, like antimicrobial resistance, ending childhood obesity. You've mentioned alcohol as well too. Air pollution is a new one on the horizon. I don't think that the aspiration of having a treaty should stop the developments and aggressive action in national, subnational, and global public health until you get the treaty. In the case of tobacco control, there was from the very beginning a hesitancy by some big countries, actually Western countries, that oftentimes treaties end up to be dead letters. And we certainly have a lot of experience that some treaties within health and outside of health are either undersubscribed, very few countries ratify them. They aren't well funded for their implementation. there's not much compliance, and there's not much ways to ensure compliance. I think this, certainly if you're going to use a model of a process in health anyway, and WHO is an example, the Framework Convention process is a good one because it has been an area which has attracted quite significant donor funds. I think very small compared to climate change, for example, but there have been some very fortuitous developments in the sense of Michael Bloomberg and Bill Gates coming on board. If this model is to be applied to other treaty processes, I think this is the model to use in the area of health. But again, being an international relations specialist as well too, and that's why I pointed out certain factors. Of course, you need to have the evidence, you need to have the technical package components with the evidence, you need to have the political will as well too, but you also, it's very much embedded into a context of international relations and how warm or cold the international sphere is to multilateral solutions. So there may be other ways of doing treaties as well too, that if UN organizations as a platform, you can't get all countries on board, you may need to do, for example, what has happened with the Landmines Treaty. Landmines Treaty, you had certain friends of the Landmines Treaty, I think it was Canada and some of the Scandinavian countries that said, we'll provide the platform for negotiation. We can invite UN agencies as well too, but we're going ahead with this as well too. If you have a surfeit lack of embracing multilateral solutions, and certainly we see in post-financial crisis right now a very worrisome trend, I think, in the maintenance of multilateral institutions created after the Second World War, as is much spoken about now. And that also affects the degree to which we can necessarily launch new treaties within the UN system and health treaties within the governing body of WHO.
So to be continued. I mean, I think this was a tremendous overview of public health history in the making, really. And our history is so important, and I think it's essential, and it was great, Doug, from your perspective of being through all of that, to be able to share, you know, the big picture and some of the details and the important factors that have been able to move everything forward. And I'll point out that even though the U.S. is not a party to the Framework Convention on Tobacco Control, as you mentioned, Ruth Romer, Alan Taylor, Dick Daynard were key in moving, so those are all Americans, key in sort of doing some of the architect work of moving this forward. So even
and Michael Bloomberg and Bill Gates. So
well,
I mean,
there are tons of people, but those were some of the early folks, the lawyers, to do some of that key work. So,
but having
we
said,
can be proud.
Having said that, Tommy Thompson, who was the health minister for George Bush Jr. as well too, did push the Republicans to sign the treaty. So at least it was a first step. Signature doesn't mean that you're legally bound, but at least there was an intention at some time to do it. So at least the door is still open, actually.
So thank you for taking us through all of that. Thank you for your tremendous contributions to global tobacco control and NCD prevention. And so please, everyone, join me in thanking Doug Bettcher for
Thanks for the invite. Always glad to come back to Johns Hopkins. Yes, any speakers. Thank you very much. Thanks for